right. Well, thank you for having me here today. Some of those, I will recognize that some of those questions were especially difficult that were just answered. So I'll try and, especially the percentage questions, I'll try and go over those as best I can. Although I'm not sure I'm going to do them justice. You're going to see there's a lot of gray areas when we're talking about diagnosing and in particular diagnosing C. diff in patients with IBD. I do want to acknowledge Ashwin and Krishnan who started these slides for me, and I made some amendments to them. So what I'm going to do is I'm going to talk a little bit about the pathogenesis and risk factors of C. diff, just briefly, and then go into clinical features and how we diagnose C. diff, and then we'll go into treatment of primary C. diff infections, as well as refractory. And we'll spend a fair amount of time talking about recurrent C. diff, as this is a major challenge in our patient population. And then we're going to finish up by talking about some key points to remember from this discussion. So, as most of you know, in the last couple of decades, there's been this enormous rise in the incidence of C. diff, and obviously this comes at a great cost in terms of morbidity, as well as healthcare costs to our patients and the healthcare system. In addition, there's been this rise in community-acquired C. diff. So historically, it's been thought that C. diff was a disease that occurred in patients who were hospitalized or a nursing home setting, although recently, in particular, there's been a rise in community-acquired C. diff. And the key distinction is that these patients have not been hospitalized, and they're most of the time younger, more likely to be female, and less likely to have antibiotic or acid suppression, antibiotic use or acid suppression use. So what are the risk factors? So in the non-IBD population, the risk factors include older age, patients who have more illnesses or greater comorbidities, as well as an impaired host immunity, which kind of goes hand in hand with older age. Extrinsic risk factors, as we all know, are antibiotic use, proton pump inhibitor therapy, and then a recent hospitalization. And in particular, some of these overlap in the IBD population. So the greatest risk factor in an IBD population is antibiotic use in the last 30 days. Patients with colonic disease are much greater risk than patients with isolated ileal disease. And then also patients on biologics have a higher risk factor for developing C. diff. And this goes hand in hand with more, so you'll see on subsequently that diagnosing C. diff can be difficult to distinguish between active disease activity. So this goes hand in hand with patients who are more likely to have disease activity and more likely to have symptoms of their IBD. So if we look at this in kind of a schema, so if we take patients with risk factors for IBD, or excuse me, risk factors for C. diff, where they encounter an exposure and then they're colonized with a spore, and these spores produce toxin, and then a subset of people will develop an antitoxin response, and so these are who we refer to as carriers of C. diff. This is very common in infants, less common in adults, so about 2 to 3% of adults. Although we actually, our group led by Dan Michik, published a series a couple years ago that showed that in IBD patients, this is about 8% of patients with IBD are asymptomatic carriers of C. diff, so they test positive even though they don't have symptoms of C. diff. And then the people who do not develop an antitoxin response obviously develop colitis and symptoms of colitis. The challenge here is that patients with IBD and C. diff, the C. diff can be indistinguishable from their IBD flare, so they can have diarrhea with or without overt bleeding, abdominal pain, leukocytosis, low albumin levels, and anemia. So it's really difficult to distinguish, is this C. diff or is it IBD or is it both? And imaging typically is not super helpful because patients will have nonspecific findings of inflammation, so wall thickening on CT or increased vascularity. And if a patient's unlucky, they can have toxic megacolon in the setting of severe disease, which, as you know, can also occur in severe colitis, severe ulcerative colitis as well. On endoscopy, one thing to note in the IBD patient population, it's been shown that patients with IBD are less likely to have pseudomembranes, as shown in this picture on the left. Whether this is due to a difference in immune response in the IBD population or the fact that patients with IBD are more likely to be carriers and they're testing positive for C. diff and don't have true infection with pseudomembranes is not known. I don't have a picture here of the classic histology, but the classic board question is that on histology you'll see this volcano lesion erupting from the epithelium in patients with C. diff, and that can occur with or without IBD. We categorize C. diff into disease severity, and so mild to moderate disease is patients with diarrhea alone, and moderate is patients with typically over 4 liquid bowel movements per day. Severe disease are patients with a low albumin plus either an elevated white count or abdominal tenderness on exam. And then severe and complicated disease are typically patients in the ICU who have hypotension or high fevers and signs of end organ damage. So there have been numerous studies in the last decade or so that have looked at the morbidity of C. diff in the IBD patient populations, and all of them show greater morbidity in our patients with IBD. And these include greater risk of colectomy, increased mortality, longer hospital days, greater hospitalization costs, an increased need for emergency room visits up to 1 year after their diagnosis, as well as need for escalation of their IBD therapy. This is a really important slide here in talking about how we diagnose C. diff, as the recommendations for diagnosis have changed in the last couple of years based on the IDSA guidelines. So the first two methods, so toxigenic culture and the cytotoxin neutralization assay, are not commonly used. If you ever see these, the cytotoxin neutralization assay, essentially you put a stool lysate on a bed of fibroblasts and look for lysate or lysis of the fibroblasts, and then you repeat that in a separate petri dish with the fibroblasts and an antitoxin to C. diff. If the cells don't lyse, that suggests there's C. diff toxin present. So a good test, but not feasible to run in most labs. GDH is a protein in the coat of C. diff and does not detect toxin. So it's not recommended to use GDH alone as a test to diagnose C. diff. C. diff overall, it has a high sensitivity but a low specificity. So if you have a high GDH, or if you have a positive GDH, it's recommended to reflux to either a toxin-based test. And we're talking about toxin, we're typically talking about an enzyme immunoassay against the toxin, so actually detecting toxin in the stool, or a PCR-based test. The toxin-based test has a lower sensitivity but a high specificity. So we think of this as often patients with a true infection. I'm going to go over on the next slide. Often will have a positive enzyme immunoassay. The real-time PCR has a high sensitivity and high specificity. The thing to know about real-time PCR, however, is you need a lower threshold of C. diff in the stool to trigger a positive test by real-time PCR. And you're detecting, although the real-time PCR is detected against the toxin, is DNA against the toxin, so you're not actually detecting toxin production with a real-time PCR test. So you can get patients who test positive by real-time PCR who are carriers of C. diff who do not have an active infection. So the current IDSA guidelines recommend a two-step testing algorithm. So either doing GDH and a toxin enzyme immunoassay, reflux to PCR if the GDH is positive, or if the toxin is positive and the patient has a positive test. Or they have a caveat in there for patients having over 3 liquid bowel movements per day, which is common in our IBD population, that you can run a PCR-based test. So one question that's come up really in recent years, and we see this in our IBD patients, this comes up very frequently, is are we overdiagnosing C. diff given the epidemiologic data that shows a really high, great increase in C. diff in the population overall, and because we're sending PCR more frequently in these patients, are we detecting patients who are colonized and treating them as if they're C. diff? And as I mentioned earlier, our group showed about 8% of patients with IBD are asymptomatic carriers of C. diff. There was this really nice study that was done out of UC Davis that was published a couple years ago. So they took hospitalized patients. These are not IBD patients, by the way. Hospitalized patients with diarrhea. It was a huge cohort, about 1,400 patients, and they ran both a toxin enzyme immunoassay as well as a real-time PCR-based test. They did not release the real-time PCR-based test to the clinician. So treatment was only based on the toxin-based test. And what you can see here in this pie graph is that you nearly double the amount of positive tests when you include the real-time PCR results. And if you looked at the results in this population, the patients who were PCR positive, toxin negative, had a less bacterial C. diff load, less antibiotic exposure, less fecal inflammation, and less diarrhea overall. And then when you looked at overall the poor outcomes in this population, all the poor outcomes were associated with people who were toxin positive, whether or not they were PCR positive. So the patients who were PCR positive without toxin positive generally had good outcomes. And keep in mind, those patients were not treated at all. So this raises the point of these are the so-called carriers of C. diff that we're detecting a high rate of PCR positive tests in patients with diarrhea who are hospitalized, and we may be identifying carriers. And it becomes really hard in hospitals such as ours where we don't have the ability to do a toxin-based test at the current time. So what are the treatments that are available for treating C. diff? So there's really two treatments right now that are recommended. Metronidazole, as many of you know, can be an effective treatment in patients with mild disease. It's no longer recommended by either the IDSA or ACG as a first-line treatment, so it should really only be used in settings where patients are intolerant to these other therapies or there's a cost advantage, which there is in many cases to using metronidazole up front. The other two options are vancomycin, to give 125 milligrams 4 times daily for 10 days. Some clinicians will use higher doses of vancomycin. There's very limited data in giving higher doses of vancomycin. IV vancomycin has no role in the treatment of C. diff. There is a role for IV flagyl in the treatment for C. diff in patients with severe disease. And Fidaxomicin also can be used as a first-line treatment or in patients with recurrent disease at 200 milligrams BID for 10 days. How do these treatments compare to one another? So there's not much in the way of direct comparisons in clinical trials. This was a randomized controlled trial published over a decade ago that compared metronidazole to vancomycin. You can see here in patients with mild disease, these were equivalent, but in patients with severe disease, vancomycin was substantially superior to patients treating with metronidazole. And then the group out of Cedars-Sinai looked at their cohort in both Crohn's and ulcerative colitis. On this slide here, I only have the ulcerative colitis data presented, where they looked retrospectively at patients who were treated with vancomycin or metronidazole. And you can see when you compare the two, especially in terms of hospital readmissions, vancomycin was superior in terms of outcomes compared to metronidazole. And for this reason, coupled with the recent guidelines, I'd recommend using vancomycin or Fidaxomicin as a first-line agent in patients with IBD for sure. And then what about Fidaxomicin and how does this compare? So Fidaxomicin, this is data from the phase 3 randomized control trial that led to the FDA approval for Fidaxomicin. And you can see here that in this non-inferiority trial, the two treatments were equivalent in terms of curing C. diff, although in terms of preventing recurrence, Fidaxomicin has an advantage with about a 10% benefit overall. One question that comes up frequently, especially on our inpatients, is whether to increase immunosuppression. As it's always a little bit scary in patients who have an active infection, is do we increase their immunosuppression to treat their inflammatory bowel disease? There was a single retrospective study that did show worse outcomes in patients with antibiotics who had added immunosuppression, although keep in mind that this was retrospective, so this is likely biased based on disease activity in the patients who needed escalation of immunosuppression. Generally, it's recommended to avoid escalation of immunosuppression in the setting of an untreated C. diff infection until the C. diff is untreated. Although, to be honest, in the majority of patients with IBD who are hospitalized, they need both. They need treatment of their C. diff as well as treatment of their IBD in order to get them into remission. So keep in mind that C. diff patient 1 may be colonized with C. diff, so this may not be an active infection. Then patients who have active infection, it's kind of this cycle where that may promote inflammation and versus the inflammation is there and the patients get worse and are colonized with C. diff. So oftentimes they need treatment for both. How do we handle refractory disease? So when we're talking about refractory disease, we're talking about patients who are not responding to antibiotic therapy for their C. diff. This is a minority of patients. So patients who have severe complicated disease should have a surgical consultation. And then typically the mainstay of treatment is oral vancomycin with or without IV metronidazole, and you can consider using vancomycin retention enemas, especially in patients who have an ileus and cannot tolerate oral therapy. There's some small trial data looking at tigecycline in combination with vancomycin showing a benefit, and then also limited data looking at IVIG. There's some increasing data showing that FMTs are effective in this patient population. Keep in mind when we go over the data presenting the efficacy of FMT on subsequent slides that FMT in patients with refractory and severe disease, they oftentimes need more than one FMT to clear their C. diff infection. What about recurrent disease? So when we're talking about recurrent disease, in contrast, we're talking about patients who respond to antibiotics but then have recurrence of disease once their antibiotic treatment is complete. And this is a much more common scenario than patients with refractory or patients who don't respond to antibiotic therapy. So the risk of recurrence is about 20% after the first episode. For patients who've had one recurrence, it increases to 45%. And for patients who have two recurrences, it increases to up to 65%. And the risk factors for recurrence, obviously, is continued antibiotic use, antacid use. In this particular study, they didn't specify, but this does include both H2 blockers as well as PPI therapy. And then patients who are older age are also at increased risk for recurrence. So we want to identify and eliminate the sources, if possible, for reinfection and risk factors that they have, such as ongoing antibiotic use. For patients who've had a recurrence, suppose they've had a recurrence after a short course of vancomycin, options include two. One is to go back to vancomycin, but to do a longer course, or go to Fidaxomicin. And for patients who have had a recurrence or two recurrences, then it's time to start thinking about fecal microbiota transplantation in that population, as the FMT is vastly superior to recurrent antibiotic use. Other options are to use a monoclonal antibody against toxin B. So there's a drug that's on the market called bezlotuximab that I'm going to show data of that is effective in preventing recurrence in high-risk individuals while they're on antibiotics. There's limited data looking at rifaximin chaser, so using your antibiotics and then giving them a course of rifaximin afterwards. And then there's decent data showing that antibiotics, in particular with Saccharomyces boulardii, after they're treated with antibiotics, helps prevent recurrence of C. diff. Again, these are not particularly looked at in an IBD population, but in the general population with C. diff infections. So this is data here is looking at data with bezlotuximab. So this was studied, this is a monoclonal antibody against toxin B. This was studied in combination with a monoclonal antibody against toxin A that was not shown to be effective. You can see here that the groups that got the bezlotuximab had about a 10% prevention of recurrence compared to antibiotics alone. So this was FDA approved as a single infusion. It's a 10 milligram per kilogram infusion. The insurance companies will typically only approve it while a patient is on an antibiotic course, but can be given as early as their patient's first antibiotic course for C. diff in high-risk individuals. What about FMT? So this is the data from the first randomized control trial of FMT for recurrent C. diff infection. And keep in mind, if you look at the data, and this was just published 6 years ago, so fairly recently, this was given by nasoduodenal infusions. The trial was actually stopped early because of efficacy. And you can see here with a single infusion, 80% of the patients had cure of their C. diff or prevention of recurrence, compared to just 30% of patients who had a recurrent course of antibiotics and a group of patients who had recurrent disease. So FMT is vastly superior to retreatment with antibiotics in patients with recurrent disease. We can give FMT through a variety of means. So oral delivery methods include a nasogastric tube, EGD with delivery to the stomach or duodenum, and more recently we've been giving this by capsules as well. And then lower GI delivery includes colonoscopy, which is the most common method for delivery of the FMT, but you can also give it by enema or flex sig in selective individuals who can't get a full colonoscopy. The efficacy seems to be best in patients who receive this with a colonoscopy when it's delivered to the proximal colon or ileum. The upper GI routes of delivery have about 80% efficacy, with about 90% in patients who receive this with colonoscopy. If you give it by enema or flex sig, it's about 80% efficacy as well. What about FMT in patients with IBD? And here we're not talking about FMT for the treatment of IBD. We're talking about FMT for the treatment of C. diff in an IBD population. And there's been 3 studies that have looked at this and been published fairly recently. So the University of Minnesota was one of the early adopters of giving FMT for patients with recurrent C. diff. So they published their experience in 43 patients with inflammatory bowel disease, and they had a 75% response rate in patients with IBD in terms of curing their C. diff. And this compared to 92% in the non-IBD population. A second multi-center cohort had a response rate of 80%, and a meta-analysis that included data from both these studies had a response rate of 80%. So keep in mind this 75 to 80% response rate in the IBD population from FMT is lower than what's been published in the literature for non-IBD populations. Whether that's differences in the host, so differences in the microbiota or immune factors associated with IBD, or the fact that our patients with IBD have diarrhea frequently and they're being retested and are carriers and not having true recurrent infections is not known at this point in time. A question that comes up commonly as well, given that we know that the microbiota plays a role in directing inflammation in patients with IBD. Will patients worsen or improve, for that matter, after they're given an FMT? This meta-analysis looked at FMT in over 500 patients with IBD who received the FMT for treatment of their C. diff, and about 15% of patients reported worsening of clinical symptoms. When they looked at good quality studies, however, it was lower, about 5% of patients. Keep in mind that's clinical symptoms, so we don't have data at this point in time that the FMT actually worsens mucosal inflammation. In immunosuppressed individuals, there's not a lot of data looking at the treatment of FMT in immunosuppressed individuals. There's one kind of mega case series, so to speak, that was published in the Red Journal a few years ago, where they looked at 132 patients. And overall, the rates of efficacy as well as safety were similar between immunosuppressed patients and non-immunosuppressed patients. And in fact, most of the poor outcomes were seen in patients with IBD associated with clinical worsening of their symptoms after their FMT. However, many of you know that in the media this has been highlighted recently. There was recently a patient who died after receiving an FMT, who received a fecal transplant from a donor who had extended spectrum beta-lactamase E. coli, and the patient was immunosuppressed and actually died from a complication of this bacteria. So it is recommended in immunosuppressed patients to talk to patients about this risk, as well as screen for these resistant bacteria in the donor's stool. Probiotics, as I mentioned earlier, this was looked at in a Cochrane meta-analysis that showed that overall, when you're looking at across probiotics, there is efficacy. Most of the data is around Saccharomyces boulardii, but there's other probiotics that have shown efficacy in prevention of C. diff, and it prevents the risk of C. diff by about 60%. Less data in patients with IBD and prevention of C. diff infection with probiotics. And then what about giving vancomycin as a preventive measure for C. diff infection in patients? There's very limited data in the literature. There is some retrospective studies looking at giving vancomycin in patients who've had C. diff before while they're on a recurrent course of systemic antibiotics that have shown a benefit. So in my practice, although this is not well driven by the literature, in patients who are at risk for or have had multiple recurrences before, if they do need to go on antibiotics soon after their fecal transplant or soon after the recurrent course of C. diff, I'll give them vancomycin while they're on systemic antibiotics. In some special populations, so C. diff can occur in a J pouch. So if you have a patient who's having recurrent pouchitis that's not responding to traditional antibiotics or biologic therapy, if that's the case, it's worth checking for C. diff and treating C. diff if it's positive. You can also detect C. diff in ostomy, so patients have C. diff enteritis, as well as in a diverted bowel. It's debatable whether those are active infections or carriers, and treatment should really be based on the individual patient and their symptoms and clinical findings. So some take-home points here to remember. So C. diff is common and impactful in our patients with IBD. You need to have a high index of suspicion since clinically it's not distinguishable from active IBD and may co-occur with worsening of mucosal inflammation. If possible, diagnosis should be made with a toxin-based testing strategy or a two-step testing strategy if there's a high rate, as there's a high rate of IBD patients who are carriers of C. diff. Oral vancomycin and Fidaxomicin should be given as first-line treatments in patients with IBD, and recurrence is common in patients with or without IBD. So for patients who are treated with vancomycin and have a recurrence, they should be treated either with Fidaxomicin and given a longer course of vancomycin, and then if they have a recurrence after that, it's worth discussing with the patient, giving them a fecal transplant for their recurrent C. diff infection. And I want to thank you for your time. I know I went a little bit over there.